Welcome our next guest. Our next guest is the Medical Director and Chief Surgeon of Gulani Vision Institute, Florida, Dr. Arun Gulani, and he will be speaking about fixing refractive error surgery complications up to 2020. So good morning, Dr. Gulani. I guess it's a morning over there, and welcome to the Advancing Optometry Education Conference, and thank you for being here with us.
Thank you for having me. Can you hear me?
Yes, I can hear you.
Thank you so much for the invite. It's a pleasure to be here with some of my real dear colleagues. Dr. Quresh, again, wonderful, passionate talk. I love how you keep raising the bar on ophthalmology. It's something we keep needing to do. Dr. Harris, wonderful talk. Excellent. Should I share the screen now?
Yes, sir, please.
Okay, here we go. So my whole concept here is talking about refractive surgery complications, which is over 80% of our practice is fixing complications, and it's a passion. And I keep trying to emphasize an important thing to colleagues, and especially optometry, that all of these can be corrected into 2020. So I don't like people just giving hope. There should be actual performance to perfection. And I like to call this don't stop, but top the train wreck. And that's a very important mental attitude, very, very important mental attitude, because a doctor who's just trying to help is never aiming for perfection. It's just trying to give hope. And I like 2020 as an endpoint, no matter what complication or refractive surgery. All my presentations are audio, publications, talking on podiums, anything you see, I always show my patients. I believe that's the highest accountability that you can ever have. Any white paper can be fudged. Anybody can say anything, but a fully paying patient of extremely high IQ on camera never lies. That's why I keep trying to show that, not only to show the outcomes, but to inspire people that this can be done. Paying homage to some of brilliant colleagues who I came across on my journey, who co-inspired me as I kept on explaining my concepts of raising the bar to everything corneoplasty. So I want you to look at a few things. So I break all the barriers you've ever had in your mind about topographies, complications, severities, which I don't like to talk about severities because to me, everything is unique. So you can see topographies. I'll show you up to 34, up to 48 diopter astigmatism, which are corrected to 2020. We'll go through these cases one by one, but I want you to keep looking at these and keep looking in your mind that all this can be performed. Here is a patient with 9 surgical complications. That's called a hexagonal keratotomy. How we control that, bring the astigmatism to 1.4 and then do a toric premium lens, and more importantly, bring the patient to 20/25 vision without glasses. I always talk about without glasses, very important. These are patients with really keratotomies and incisional corneal refractive surgeries, all of which from 4 to 32 diopters can be corrected to 20/20. Just neglect looking at the scars. It doesn't matter how many incisions. These patients actually think this way. Their surgeon, whoever did this surgery, wasn't crazy. Even though I never agreed with RK and never did a single RK, today I have the biggest practice in the world of fixing RK. And I say a very simple sentence: their surgeon, whoever did RK, did it to make them see. So obviously these cuts work, no matter how horrible they look, and take them back to 2020. Here are patients, again, it's a terrific video to show you. This is the worst RK case I've ever looked at. Over 20 cuts, full thickness opening, fully central scar, completely blinded oral surgeon, very famous oral surgeon, did a lamellar keratoplasty in him, followed by cataract surgery with premium lens, and straight to 20/20 vision. Again, all these are concepts I want you to look at, that there's nothing abnormal. Patient had about 16 diopters irregular astigmatism. Cornea was 200 microns. My refusal to do a penetrating keratoplasty, have not done one for 23 years with the referral practice of all irregular corneas from all over the world. Very important. Attitude is very important to bring these patients to perfect vision. Patients with 30 cut incision RK, patients with astigmatism, the over 16 diopters. You can see here, you can use future technologies. Again, that's the video showing the DEXIQ implantation in the eye of the eye drop, which you don't need eye drops anymore, which is what I do. You can use technology to the fullest, even in these complex cases. That's a toric premium lens, and straight to 20/20. You can see the pre and post-op photo of the patient. How many surgeries has the patient had does not matter. These are patients who come to me with 9, 10, 16 surgeries this week. This patient from Egypt came with multiple surgeries on his keratoconus, multiple failures, 2400 vision, leaving with 20/25 vision, and came back actually for another eye surgery, for his other eye, sorry, when he came back. Again, these videos are vital. I hope someone's working on this. I like to share how I come up with these results. It's something that you do every day as optometry. You think about optics. That's how I think. What I try to emphasize to my colleagues, eye surgeons, is not to think surgery. Think optics and vision, and your surgery will become artistic automatically. And you'll be very nimble as a surgeon, as opposed to doing crazy stuff in the eye, tearing up the iris, stitching lenses, and playing with the vitreous. Be very sensitive to 20/20 in every situation. So that was this slide. And this is refractive surgery. These are all patients who've had refractive surgeries, blinded by different situations, and they all can be corrected within minutes. Here's another patient, South Africa, nystagmus, high hyperopia, astigmatism, +9 hyperopia, +7 astigmatism, every anomaly, including labeled as amblyopia, straight to 20/20. That's an instrument I've designed to hold people with nystagmus while I do their laser surgeries. And again, this video would be terrific to see how they came to this visual endpoints. Another patient here, nystagmus, amblyopia, albinism, transplant over keratoconus. I consider every surgery as a refractive surgery. So even if someone comes to me with a transplant or retinal surgery, it doesn't matter. I want 20/20. I tell my fellows, if they have a patient with a knife in the eye stuck with a stab, I still want a one-page report of why that patient's not 20/20. That's the attitude I want everybody to have. Here's this patient again. You can see the topography, 11.8 diopter, astigmatism doesn't matter, straight to 20/20. Here is a great way of thinking, how I think in these cases. Here's a patient done by a very, very brilliant surgeon, keratoconus with hyperopia. This doctor underwent and put in a premium lens implant to me. That is also refractive surgery. Patient ended up with a hyperopic surprise, central corneal scar. Of course, keratometry is high because of keratoconus. And then they opened the PC with a YAG laser. So now you're left with a pseudophakic patient with an open PC and keratoconus and poor vision, extremely angry and wanting to sue the surgeon. Here's how I think. I like to line up all the optical errors of these patients, like as if in a game of bowling. And what you do there is you line up each of the pins. What are the issues that are there? Then you decide the plan. And then last you come up and look for technology in your kitchen to deliver the perfect vision recipe. So what did I do in this case? This is my thought process, which is very important. Many amazing surgeons saw him in the country, but they all were jumping into, I will remove the lens, do a vitrectomy, suture the lens, I will correct it this way. They're all missing the point. 20/20 has to be achieved. Cannot just do surgery and leave the patient blind. So here my concept became, how do I make him myopic? Because myopic laser ablation will get me all the pins. I will be able to flatten the central cornea, remove the scar, decrease the keratometry of the keratoconus, bring the patient to emetropia without even touching the inside of the eye. Problem was, he's hyperopic. How do I make him myopic first? So these are concepts where I go. I tell these patients, I agree, our ticket with me for you is to go to Paris, but let me take you to Iceland first. So what I did first in this case, I put a piggyback lens, made his vision worse, and he had to have confidence in me. And at that point, I made him myopic. And could I put a piggyback lens, keratoconus eye, deep chamber, perfectly done by his previous surgeon. 3.5-minute surgery. We went into a same incision. Again, all corneoplastic principles, no pain, topical, etc. After doing that, I waited for refractive stability. Then I went with the laser, corrected as -1.5, and astigmatism on the scar, decreased keratometry, not only to 20/20, 20/15 vision. So that's the pattern of thinking, which is very important for surgery. The planning system I have, I always plan for vision backwards to technology, never technology first, always surgery. And then the planning system involves all the techniques. Just like you in optometry have so many ways to do glasses, Dr. Maskati explained about prisms, you have contact lenses, you have combinations of all these. Similarly, in ophthalmology, there are so many concepts. I hate the fact that doctors call themselves LASIK or cataract or corneal surgeon. There are 40 vision corrective techniques, must be a master chef to deliver all of them. Now, we'll go straight to the first and most important surgery, which is LASIK, which many of y'all see. LASIK, I'm also combining SMILE and PRK. A lot of these complications keep flying to us. This is one of the most successful surgery, but even these complications can be corrected. My point being the excimer laser is the extension of our own tolerance at submicron precision. And training this is about nearly 3 decades ago when LASIK was first being done in the US. We had already performed one of the world's first LASIK surgeries in the 1990s. And I started designing instruments knowing that many surgeons were jumping into LASIK without knowledge about cornea, and started teaching and training doctors, and slowly saw my practice becoming a real referral place for complications. So we invented instruments, protocols, brought all this to light to keep on improving the realm of LASIK surgery. And this classification system that I authored in 1996, it still holds good for how to break down complications. I hate the fact that doctors give names to complications, like this is LASIK, this is smile complication, this is PRK. It's all corneal. It's very simple. Divide it into the anatomical zone and you suddenly have an answer of how to correct it. You don't have to keep on thinking and calling it names and get scared and have no treatment. All right, so if you look at this classification system, happy to send that to you. It still holds good today, 3 decades later, of how to address corneal refractive surgery complications. So this was the thing I drew up again 3 decades ago. And if you see the levels, level 1 is buttonhole, small fab, incomplete pass. Then we have infections, interfaces, level 2, epinest, toxic interfaciitis, infections, blood deposits. And final is the ablation area, which is you can have decentered zone, improper ablation areas. Patients complain of halos and glares and night vision issues. And this holds good even today. So one of the most common complications of LASIK and all these surface techniques are dry eyes, which all of you know how to correct, and we'll go into that later. Patients with buttonholes, and all of these are pretty much down to zero today because of the technological advances that we don't use microkeratomes, and even the femtolasers have become so much better in these techniques. In my particular case, I actually do laser plastique nearly 100% of the time, so there is no flaps at all. These are buttonhole patients which can be fixed. Again, the video, I wish you guys could see the videos. These are terrific videos that you could see and how these can be fixed straight to 2020. Patients with wrinkles in the stria, micro or macro stria. Again, this is a video showing you how I fix wrinkles within minutes, and these patients go to 2020. Patients with hinge burns, which we don't see nowadays, interface debris. DLK, as you know, I had called this condition toxic interfaciitis at that time in 1990s. By Dr. Bobby Maddox, it was called Sands of Sahara. By Dr. Steve Slade, it was called non-specific diffuse interfacial lamellar keratitis. And this situation can still exist today. Treatment is very simple. Again, LASIK flap infections. And how do I treat them? This is another video. I have a request, just because I have these amazing videos for you guys to see. Is there any way we can check the preferences on your site to see why my presentation is not working?
Could you check the advanced sharing options to see if we have any menu for videos?
Any changes? Just a second.
Could you just see any advanced sharing in the advanced sharing options?
I'm in advanced. It still says, it still doesn't have that. It says computer audio, content from second camera. That's it. No other options. Would you like me to continue, or do you want some other speaker to do this and I can come back to you?
Whatever you want, sir. We can go.
It's terrific stuff for you all. Unless you all want to go like this, I don't mind. I can talk to you all. Each of this is mind-blowing videos for you all to see how the corrections are done. But if you want, for time reasons, I can just go as slides and finish off.
If you have the time, then we would love to watch the videos. So it's up to you.
Okay, give me a minute. Let me again check why this is not working. Even yesterday, I did a big webinar. This is very simple. Something's going on. I'm in your system preferences. Everything here looks great. Sharing this. It is sharing the slides right now. Anyone questions, please? I can talk while we're doing this so we don't waste anyone's time. See, it is in share screen. I have it there. It does say desktop.
I request our audience members, if you have any questions, you can direct them to Dr. Gulani while you fix the issue.
Now, could this be the browser? Do you want me to go through Chrome or something?
Yes, sir. It very well could be, because I can see in the web that the versions that we use can also affect the video sharing.
I know, but I've done this so many times, thousands of times. Is there something on your preference size by any chance that I must go through Chrome?
Not really, sir. That's
no.
Not
Okay.
as far as I know.
I see Dr. Shaker here. Would you like to proceed with this talk, or who's next? And I can maybe figure out what's going on here.
Sure, sir. We can do that.
I'll do that.
I'll call up on the list.
Okay, just check and let me know, please.
Sure, sir. So while we deal with the technical aspects so that Dr. Gulani can share his wonderful videos with us. I would like to welcome Dr. Naveen Raj Joshi, the Senior Clinical Research Associate and Principal Investigator for Tesseract Health International Corporation, who will be talking about pupillometry in traumatic brain injury. Dr. Naveen Raj Joshi, are you here with us?
Actually, Manishi, I guess
Yes.
Dr. Gulani has the preferences to make these co-hosts and everything. So maybe Dr. Gulani can make a co-host for the Dr. Naveen. So then after he can unmute himself.
Yes, what is that?
Doctor, can you please make Dr. Naveen as a co-host?
Dr. Levine.
Naveen, sir, Naveen.
Naveen, only Naveen. Maybe.
I've just come out of the share screen.
Yes, so if you will just put the participants and type in Naveen Joshi and request him for being co-host.
Okay, and then ask to unmute more. Make host, is that, or make co-host?
Co-host, sir.
Co-host.
There you go. I'm done with that. Make co-host. He's done.
Thank you so much, sir. Dr. Naveen Joshi, can you hear me? Dr. Naveen, are you there?
Yes. Can you hear me?
Yes, sir. Yes, sir. I can hear you. Hello, sir. Good evening, and welcome to the Advancing Optometry Education Conference. And thank you for being with us.
All right. Let me see if I can easily share my screen, and let's see if you can see it.
Yes, I can see your screen.
All right. Yeah. So again, I should be really brief, and thank you again for the invitation. And it's always good to connect back to the optometrist in Nepal and in Asia. So I put together a really brief summary of the utility of analysis of pupils and pupillometry in traumatic brain injury. And pupillometry and pupil analysis is just not for optometrists, but the neurologists use it. Primary care practitioners, they have some training on how to use it, as well as ophthalmologists and others as well. And traumatic brain injury especially gained a lot of attention after the wars in Iraq and Afghanistan, and road traffic accidents, general accidents, and also now it's in the headlines because of sports related trauma. And optometry, ophthalmology, and sports medicine and neurologists are at the forefront of trying to document a relatively milder form of the disease. The moderate and the severe, it's really easy to pick up and diagnose, but the mild ones are really nebulous, and sometimes it's very difficult to even diagnose and manage what goes on. So just for disclosures, I'm a clinical research associate and principal investigator for Tesseract Health and other companies for Ford Catalyzer. I work on myopia control with Kubota Vision. I'm also a federal grant reviewer for the Department of Defense. And I also am a consultant at Children's Hospital of Philadelphia and their concussion department. And I also work with J&J. And coming into how I've sort of compiled the information, it all comes from mainly 3 published articles. This article we published in around 2017, looking at a general review of literature of whatever is present in pupillometry in traumatic brain injury. And also we published some in Journal of Optometry, and recently with the investigators at UPenn, we also looked at how pupillary metrics are affected in adolescent sports-related concussion in athletes. So why pupillometry? it is really fast and objective. It's not a subjective thing. You can lie with your pupils. And it has a relatively well-established neurophysiological pathway. So when a pathway in any nerve disease is known, then it's relatively easy to come up with mechanisms and study the whole thing. And we also know the biomechanical properties of the pupil really, really well, because pupil is one of the most studied ocular biomechanical structures alongside extraocular muscles and accommodation, of course. And it is the only thing that gives us a good indication of autonomic functioning in the eye because of the parasympathetic, sympathetic, and a lot of blood flow and muscle-related activity. And also it provides multiple independent metrics, the metrics that are independent from each other and just not dependent on the same parameters. So biomechanically and neurophysiologically, we look at the pupils, and this is actually done through a pupillometer. It's not a simple, relative afferent pupillary defect swing of flashlight. So when we actually look at the pupil, we can get the baseline diameter, the diameter that it's setting at. And once the stimulus comes on, the pupil is heavily directed by the light stimulus. So before stimulus on, pupils can be directed by how well you slept that night, or what did you eat, what's your mental alertness, or everything. But once the light comes on, it's primarily driven by the light and by nothing else. So from the moment the light comes on to when the pupil actually starts constricting, there's a latency. And this is because the light information has to be processed by the retina. It has to go to the brain, and from the nuclei in the brain, they got to come out and then come to the sphincter muscles through the Edinger-Westphal. So that neural latency is taken care of this. And the reason that pupil constricts first is because the time it takes from the cortex or the brain to get to the constrictor muscles is relatively shorter, because if you remember the sympathetic pathway, it goes all the way down from the hypothalamus, goes to this, goes to the almost the thoracic region of the spinal cord, comes back up. So because of that long duration, the pupil actually starts dilating later. That's why it constricts first. And looking at it as a biomechanical tissue, you can look at the peak constriction velocity. So this is, if in a car is 0 to 60, right? It's the peak. And then you can average it over time. It reaches a minimum diameter. Then it starts to dilate. And these things are very much controlled by the actual plant, means how the muscles and innervation sort of comes together. And it's very different in multiple species of animals. So I'd like to let you know that caution should be exercised when we're trying to look at animal models of pupils and human models, because it's a world of difference. And you can look at the time that it comes back to 50% of the baseline, 63% of the baseline, 75% of the baseline. So these are just biomechanical properties of, like, let's say a spring. How effective is the spring is based on how fast it comes back to the baseline height or the diameter. And also we can look at delayed pupil diameters, especially for traumatic stimuli, after a few seconds of the stimulus coming on. That is about 6 seconds. And so the reason we even looked at pupils is this is something that we published in Journal of Optometry, is because if you look at the normals who are age corrected, you can see them over here. And these are the patients who suffered from sometimes multiple traumatic brain injuries. So some of them were boxers, some of them went through road traffic accidents. Some, some person had their head, like a brick fell over. So we can see that the pupils over here are much smaller under identical conditions than the age-matched controls. So this is about 30-odd patients. And then what we did was we evaluated short pulses of light that are bright and dim, and small steps of white light that are dim and bright. And also we looked at a bright chromatic red and a bright chromatic blue. And you can see that dimmer pulses, you can see that in MTBI group, which is the dotted line over here, and the solid lines are control subjects. You can see that for dim, even latency is involved most of the time, almost all of the time. And for bright, latency is not that involved, but the other pupillary metrics like the minimum constriction and the pupil diameter at 6 seconds after the flash, and even baseline pupils. So these are affected depending upon whether it's a dim light versus bright light, bright chromatic versus bright white, or pulse versus step. So step generally means a longer duration. So pulse is generally about 100 to 200 milliseconds, and which is over here, and step is around 1 second stimuli. And it's interesting that the adults are different from adolescents and especially early adolescents. So this is data from the JAMA ophthalmology paper, where we looked at around more than 100 controls and just about 98 athletes with concussion. And you can see over here that the healthy controls, their pupils are smaller, and the athletes with concussion, their pupils are larger. And we can also see that in terms of velocities, or how fast the pupils constricted or dilated, we can see that it's faster in people with concussion, which is exactly opposite to what we find in adults. And the reason being is that the adults, we looked at chronic cases, sometimes months and years after injury, and most of them were photosensitive, means they had to wear sunglasses when they went out, they were really bothered by light. And what we think is that inside in their cortex, their perceptual gain is higher because of the trauma, and they see things, lights brighter than other people. So their cortical perceptual gain is higher, and because of that, the pupil constricts because they are perceiving everything higher. And when there's no more noise in the system, then also you start seeing brightness being tuned more towards the brighter side. And actually in adolescents, what we find is that their mechanism of injury might be excessive sympathetic tone, because these kids, they generally have headaches, they have nausea, and because of that, we think it's the sympathetic tone, and the sympathetic system is more affected in adolescents and possibly in kids. And when they go into chronic conditions, they have structural changes in the brain later on. And so I'd like to conclude that pupils are altered in a different range of traumatic brain injury, even from a simple concussion. That means you're hit on the head and you lose consciousness for a few seconds to sometimes hours. And even in severe cases, and infrared pupillometry is one of the methods of choice to evaluate these changes. And with this, I'd like to stop my presentation, and any
Thank you so much, Dr. Joshi. That was a great presentation regarding the pupillometry and traumatic brain injury. I would like to ask my audience, if you have any questions, you can direct them in the comment section, and we will discuss it with Dr. Joshi. Meanwhile, we will try to get Dr. Gulani's videos running. So I'll request Dr. Chandrasekhar Chawan to make Dr. Gulani the co-host of the presentation.
How about now?
Yes, sir, I can see the screen. Let's hope the video
Okay, great. Excellent. Looks like everything's on. That's very odd. Okay. We have 10 minutes, right?
Yes, sir.
That's good. Thank you so much, Shekhar, for that. And pleasure hosting you all now. Let's start with the meeting. And this is really my most passionate topic, which is fixing refractive surgery complications, which, as I mentioned, is over 80% of my practice. And the pleasure of presenting to optometry is you think like I do, which is vision comes first and optics come first and anatomy and surgery is secondary, and it happens. So this is my very important point to everybody, every eye doctor, is not just give hope, but actually take patients to excellent vision and perform. So don't just stop the train wreck, stop it. That's very, very important, okay? And all these are patients day one from different parts of the world who had all kinds of complications, all seeing perfect. I want to constantly show you all patients because that's how I teach. And I like to inspire by saying, these are real people and they can be helped. Throughout my presentations, as you've seen many times, including my publications, you see I always show patients because I believe there is no higher accountability than a high IQ, fully paying patient on camera. Everything else can be fudged right from your talking to your white papers. Everything can be adjusted, but a patient on camera is always speaking the truth. So Jerry Maguire stole this statement from me 2 decades ago. Remember, show me the money. So this was actually my statement, show me the patients. Giants who I have come across in my own quest for perfecting refractive surgery. We co-inspired each other as I kept on raising and discussing corneoplastic, which is my dream. And these are some amazing, amazing people who are no more here, but live in our hearts. I want all of you to understand there is no limits to the level of irregular astigmatism that can be corrected right up to 34, 38 diopters. So I want to keep on showing you things to show you that all this is possible. Here, for example, is this patient with 9 different complications following hexagonal keratotomy. It's a surgery done long time ago for farsightedness, and obviously didn't work because it caused a central island. And these patients are walking around with very poor vision. So you see what I've done here, disregarding the level of complexity, we've corrected the cornea by embracing it with intact, decreasing the astigmatism to 1.4 from 23.5, and then going ahead with premium toric surgery.
This is a 75-year-old nurse who was referred to me following hexagonal keratotomy with corneal ectasia, vision of sound fingers only, and Fuchs dystrophy, along with associated cataract and high keratometry of 88 with high irregular astigmatism of 23.5.
Keratometry is 88.
I planned first to stabilize and make her cornea measurable.
So I'm using Intacs to hug the
for
cornea
future
and make
cataract
it much
surgery.
more controlled.
Here I am using Intacs.
I'll go a little fast.
My
so you
intact
see,
rings in place.
while I'm putting the rings, I'm seeing my reflexes becoming a circle.
Can go into the hexagonal keratotomy cuts.
And you can see the circle coming up again, in the center of the cornea. I'll decrease the sound. So that to me is the end point of what I call titratable intact technique. You see the circle there? That tells me this is perfect now. The cornea has become circular. I immediately cross-link. And then having controlled the cornea, I now go and look at the patient dressing up after 60 years of blindness. And then I go to intraocular lens-based surgery. You can see there's difficulty visualization, but that's perfect. We still want to do a sutureless topical surgery, painless within minutes. And we go in with complete confidence and actually put in a toric lens implant. And again, no stitch. And we come out and the patient, you can see right here with 20/25 vision. So you can change these people's life. There is absolutely no reason not to do it. Patients with real keratotomy, many of you see these patients with different cuts, irregular cornea. It doesn't matter if it's 4 to 30 cuts. Disregard the cuts and take these patients straight to vision. This is one of the worst RK cases. It's an oral surgeon with dense central scar, over 15 diopters, irregular astigmatism, 200 micron cornea, blinded in both eyes. I just finished his second eye. So what did I do here? I first made sense of the cornea, refusing to do a penetrating transplant and disabling the patient. I do a lamellar surgery, very delicate, very risky. And you can see this cornea crooked, broken with 15 diopter astigmatism. Lots of these cuts are open. That's why the center had the scar. And you can see how I'm going gently with a blunt instrument and doing a lamellar surgery, as you can see here, separating that lamella very carefully because I can enter the eye if I make one mistake, or I could tear it upwards if I make another mistake. And then we put a donor lamellar. Here I'm pulling the scars off. That's a lamellar cornea, stitching it in place with my anti-torque suture. Very difficult because I'm also going through RK cuts while I'm doing that. And all the time, remember, my desire is 20/20. So it's not just about the surgery. That's the cornea. Then I went in, and this is before, after, and then I went in and did a toric lens implant, no stitches, no anesthesia, drops. Here, this man immediately after surgery, this is an oral surgeon. You can see how you can change their lives. This is the sequence of that man's situation. Here are patients with extreme RK complications, with ectasia, with 25 diopter astigmatisms. You can also use modern technology like the you see over here. I'm injecting this sphere of medication in the eye so we don't use eye drops anymore. You can use technology even in these complex cases and bring these patients to excellent vision. This patient was from Mass Eye near Boston. This is a patient with multiple surgeries from Egypt. You can see the Kera ring, laser, LASIK, PRK, PTK, multiple cross-linkings in different countries. Doesn't matter. Look at the patient, make a plan to make them see. And you can see with laser plastique, this patient straight to vision. He came back for his second eye from Egypt again. I want to share with you my secrets in all these surgeries and outcomes are how I think vision and not surgery. And surgery happens in an artistic mode because you're focused on vision and optics. So here we are. You can see me literally putting pieces together. This is an RK with multiple LASIK with ectasia. When he was flown to me, you can see I'm putting his pieces together. They're like broken pizza pies with wrinkles in between. I first arranged them, and the audacity of doing laser over them. No transplant. Everybody saw some brilliant surgeons went to transplant. He's a pilot. I said, no way. So you can see me doing the optics over the broken cornea. Broken in many areas I've arranged. But that is the beauty of optics and how this works. That's why I call this technique new carpet on broken tiles. You'll get that point in a minute. And you can see this in real time, what's going on. I'll go a little fast again to make up for time. And you can see again, once I finish, you can see the reflex on the cornea. Do you see that circular reflex? That to me is a straight, I call that circle of sight. And the patient immediately seeing under the laser, there cannot be a higher level of happiness and proof. These cases are refractive surgery, no matter how bad they look with RK and scars. And here is a patient from South Africa. This patient came with very high hyperopia, +9, astigmatism +7, nystagmus written off as amblyopic. No such thing. Did one eye, brought it to 2020. That's a special instrument I've designed for laser vision surgery, but I hold the nystagmus eye from moving too much and I continue my laser. And you can see these patients, how they are before and after and how they react. She went skydiving in California after this for the first time in her life. Here's a patient with nystagmus, albinism, ocular albinism, myopia of -11, myopia -9, astigmatism 11.8, has a transplant on his keratoconus, had multiple surgeries failed, and we disregard the topography, bring him straight to perfect vision. You can see the nystagmoid eye, albinism in him. And here he is. So very, very important. I'll show you my thought process. When patients come to me with these complications, I don't just jump and do surgery. I think vision. How can I make them see? And then I do the least interventional surgery. And that's what the patient wants. The patient doesn't come to you for surgery. They come for vision. And when they come to you in optometry, they're coming because they are dissatisfied with surgery and they want to make up for that in some form with your expertise, with scleral contacts, like Dr. Shekhar does. There are some brilliant optometrists. Y'all are doing the 3D print contacts. All these kind of things are important to then take these patients to vision. But in most of the situations, you can actually make them see with surgery. And for example, here's a patient. He had a surgery with a brilliant surgeon. He's a keratoconus case who had premium cataract surgery, ended with hyperopic surprise, of course, with keratometry being high from keratoconus, central scarring, and the doctor did a YAG capsulotomy, so now the capsule is open. What I like to do in these cases is not worry about the number of problems, but aim for vision again. So I line up all the vision errors, like pins, if you play bowling. And the pins are lined up here. The problems he has is corneal scar, steep keratometry, keratoconus, astigmatism, and also the lens power is incorrect because the patient's hyperopic. And there's also the fact of central optical zone. Now, The one surgery that will correct all these errors within minutes is myopic laser plastique. But how do I make him myopic from hyperopic? So I tell these patients, let me first take you to Iceland before taking you to Paris. So I put a piggyback lens, make him myopic. Got it? So 3.5 minute surgery, put a piggyback lens under drops. He's done, make him myopic. So now he is myopic with scar, with high keratometry, with central pseudophakia, with keratoconus. And with one single surgery now, 3 months later after stability, I bring him straight to 2015 vision, better than 2020. He's back to being a pilot. We reached Paris. That's the concept there. So very important, the thought process, vision over surgery. And how do I think? I always think vision first, just like you. Then I think surgery. And finally, I think technology. I never jump to technology first. I go back to my kitchen last. First, when I decide what recipe I want to provide to the patient. Then from here, we go into my planning system concept. Here we are. And that's where I take my maximum time planning for these patients' surgery and the 3T system, technique, technologies, and target. Now, let's go to the first important surgery that you see a lot of, LASIK, SMILE, PRK. I bunched them into one just because they all have similar complications, though they are very, very minimal. So LASIK is by far a very successful surgery. And this is my way of teaching LASIK surgeons. I say excimer laser is an extension of our own tolerance at submicron precision. That's very important to understand. Now, nearly 3 decades ago, in the 1990s, when I did one of the first LASIK surgeries in the world, I realized doctors were jumping and doing this surgery without understanding optics and cornea or refractive surgery background. So I started teaching courses, building instruments, innovating stuff, writing protocols to help doctors. And since then, have had a practice of second opinion and complication corrections. And the instruments we had designed are still in use today for all these complicated cases. And very, very important, that classification system that I wrote in 1996 still holds good. And if you see my style of teaching, is very simple. I don't like it when doctors confuse situations by giving it names of surgery. For example, LASIK complication, SMILE complication, PRK complication. Actually, it's a corneal complication. So if you break it down anatomically like this, you can understand where the complication is and what do you need to do to fix it. Becomes very simple. So keep this in mind. And then I had drawn up this system where I took individual cases many years ago, put them in the layer of 1, 2, 3, and you can see the corneal level complications as level 1, the ablation or the interface between the flap and the rest of the cornea as level 2, and the ablation area level 3 complication. The most common complication or side effect of LASIK is dry eyes, which you all know how to take care of, and we'll talk about that later. This is a keratograph that I use to help these people understand what's going on, and there are over 12 modalities of dry eye management. Patients with buttonhole in the LASIK flap, which are again not common with laser techniques today, can be corrected with my laser plastique. If you see it, that's a buttonhole in the cornea. You don't need to do transplants for these patients. You can do a laser surgery, as you can see here, and within minutes, the patients are seen and they're thrilled, and their major complication is brought to zero. So you can see the lasers going on here. I'm going to go a little faster for time. 10 seconds. And you can again see the central reflex that you saw right there. That translates straight to vision. This is very important to see. And that's immediately the patient goes into vision. Micro and macro stria of the LASIK flap or SMILE flap that you may see, you can correct that too with laser plastique technique, as you can see here. Look at the striae. These are micro and macro striae of the flap. So it's still level 1. You can see the striae. And I'm going straight with the laser in a refractive mode. So you're correcting their residual error as well as the flap quality, improving their night vision and halos and glares, and bringing them to perfect emetropia. Patients with buttonholing and burning of the flap hinge by improper laser placements, again, not common nowadays. DLK, all of you still see that cases, a few of them, maybe surgeon-related optometry. I had called this condition 3 decades ago, toxic interfasciitis. My excellent colleagues, Bobby Maddox from Texas, had called it sands of Sahara. And Dr. Steve Slade from Texas had called it non-specific diffuse interlamellar keratitis. But all these conditions still exist today. And the treatment for them is still laser plastique, the way I do it after controlling the infection. So you can see in this case, actually, this is an acanthamoeba infection on a LASIK area. So yes, herpes and acanthamoeba also can be corrected. I've been doing that for 2 decades. And again, I'll fast forward through the video. Here we are. I'm working on an acanthamoeba scar. following a LASIK complication. Listen to the patient.
Can you tell any difference? There's a lot more clear things.
And that's immediate. Immediate.
Any pain at all? No pain. I'm so proud of you. How many years have you suffered with this blindness? 14 years.
Can you hear that? 14 years. Doctors are still skeptical, still not treating these cases, still not helping the scars. And look at the circle of sight I'm showing you here. End of case, right there.
That tells you, again, as I teach, translates to vision.
So all these scars in the cornea, whether caused by LASIK, SMILE, PRK, or any refractive error, can be corrected. You know my in-cornea concept, where the scars become the cornea and relate to refraction, or on cornea, where the scar makes the topography looks like a clown suit. You peel those scars off and these patients go straight to 20/20. Here's a quick video of how I'm peeling the scar.
In deeper on corneal scars like these,
I'm peeling the scar off, and what you can see is, again, you see me lasering right there. This is not PDK, this is a refractive laser. And you see these patients, excellent circle. Again, you saw that this is 8 years later. This is 8 years ago. 8 years later, I did a premium toric lens implant when he had a cataract, once again bringing him to 20/20. So these are the concepts I want to share with you. No matter what the complication of LASIK or refractive surgery is, these patients can be 20/20 and be kept 20/20 for the rest of their life. Here's the sequence of that patient: scar correction and then toric lens implant, kept to 20/20. LASIK epithelial ingrowth still seen, though very rare, is my 2-3-4 rule in these cases. The protocol I had suggested in 1996, which breaks it down into visual, strength, and progression, which is, where is the epi ingrowth? Do we even need to take care of it? If it's in the periphery, is it in the center? Various treatment modalities that were used before, YAG, cryo, laser treatments. The real way to treat it still, according to me, is physical treatment, which is, you can see this here. I'm actually removing the epithelial ingrowth from the areas of the flap, the underside of the flap, and the stromal area. Remove the entire epithelial ingrowth. Here I'm lifting the LASIK flap of the surgeon and removing the entire epithelial ingrowth here. Cleaning up the flap, underside, and the area, and then hydrating and cleaning the interface between the flap and the stroma, putting it back together, and then gently using Richelieu sealant, elegantly again leaving the patient with no pain, no reaction, and done forever. You can see that right there. That's Richelieu sealant. It's a sealant, not a glue. Keeps the area of the flap down where I believe the epi had gone in for that surgeon. Now, laser malfunctions, which is level 3 complication of LASIK, which happens in the stromal bed, which are related to the laser. So it's very important to know that the laser is well calibrated. That's why I do not like people running people through a mill. Must check the laser because it's invisible between each case, each LASIK surgery or SMILE or PRK surgery. So you can have central islands, decentered ablations. These are ways of checking the laser. And you can see the concepts. Even if this laser is decentered and the patient has a complication, they can be corrected.
I see. This is an immediate difference. This is,
again, notice that there's no pain. The patient is talking right under the laser. Patients are suffering with poor ablation areas. They can all be
no pain whatsoever. Not at all.
So all LASIK complications, SMILE complications, PRK complication, no matter what refractive laser techniques, can be corrected back to 20/20. Now, when these complications are deeper, that they cause corneal instability and they come to you with ectasia, what do? I use Intacs very carefully in my titratable technique that I showed you. You can even see the reaction of these patients immediately as I'm putting a ring into his LASIK complication eye, and he sees immediately, starts seeing and starts crying. These are tough, intelligent people, but that's their reaction after years of blindness and being told nothing can be done. Watch this.
You just put a special ring to control your complications from your LASIK. Look into the light. Can you tell any difference? I can tell her hair right there. I can see her hair right there.
Can you see that?
Wow.
A few minutes, topical surgery, and you're fixing all these major complications that are told nothing can be done. There is no such thing.
Wonderful. Excellent. Congratulations. Keep your eyes closed. Keep fixed. Come on, give me a smile. Don't feel like you're crying. I don't want it. Get up.
I want you to constantly see the patients to understand that you all can change their life. It's very, very simple. Here is post-LASIK ectasia Intacs. The astigmatisms I'm bringing down from 7.4 to 0.6. Here is a patient with ectasia with multiple surgeries done elsewhere, flown to us. This guy's from the Panama. you can see this modified T-intact technique with immediate cross-linking patients straight to 20/30 vision, 8.4 diopters brought to 2.6. Again, intact for ALK. Before LASIK, there used to be a surgery called ALK. We used to cut the LASIK flap, let the cornea protrude for treatments. Those patients flying in can also be helped, you can see here. Once the ring is in place, it doesn't end there. For these patients, I can still do laser plastic on the intact ring, as you can see here, and bring them from, in this case, from 3.7 to 0.3 diopters, bring them to perfection. 20/20. Remember, our topic is not just how to fix them, how to bring them to 20/20. Here are patients with previous LASIK ectasias, all fixed and corrected. The other level of complication we are moving into now is cross-linking. There's a lot of what I call linking without thinking, right? A lot of doctors just indiscriminately linking keratoconus patients without planning to improve their vision. That is wrong because these patients are getting disabled forever. Think about the concept I'll share with you. Here are these patients flying to us with huge 17 diopter astigmatism, scarrings from cross-linkings going on. Cross-linking is an excellent concept and technology in our profession for keratoconus, but you don't use it without thinking. So if you see my concept, it's called the keratoscoliosis concept. Think of the keratoconus as a bent spine. Think of that as kyphosis, right? What's the point of putting cement on the spine and telling the mother this won't bend anymore? But isn't that stupid? Why wouldn't you first straighten the spine? So we are leaving patients, whoever's cross-linking keratoconus patient indiscriminately, are leaving patients permanently disabled. Yes, they may not get worse, but you left them permanently disabled. You could have fixed the cone first, make them see, like you see here, and then proceed with cross-linking. So that's a very important thing I want to teach you all today. Here are patients, firefighters who we've corrected from bad cross-linkings and surgeries. And of course, cross-linking I do in various kinds of corneas, right from ectasias, LASIK ectasia, RK complications, all kinds of refractive complications. And we must give credit to the man, Dr. Theo Seiler, amazing gentleman who invented this technique. Then from there, we go to deeper issues of refractive complications, which require you to change the level of the cornea. Again, remember, I do not like penetrating corneal transplants. All of you will agree, not a single patient with PKPC is 20/20 and has a lifetime of disability and issues going on. Do it only in a fully perforated cornea. Until then, there are lamellar techniques. There are about 6 lamellar techniques that I do. Here are some of them, and we'll see the use of this in deep issues of LASIK or whatever refractive surgical complication. One of them is very simple. I basically take the LASIK flap and I throw it away. Watch here. And then I make a donor flap on a donor eyeball. As you can see here, I just want to show you the keratome going on the donor eye. So that's on a donor eye. I'm creating a flap that is a little more thicker than the flap that I'm going to throw away. And I just exchange this for that, no stitches. And the patient's done. So all the irregularities and deep scar that laser plastic cannot address, you're just replacing this tissue. This is the donor cornea. I'll just replace one for the other, no need to stitch, and you're done forever. Now, if it is a deeper issue, the cornea is like so ectatic, the cornea is down to 100, 200 microns, severe ectasia, cannot make sense out of it, then you do hand lamellar surgery, as you can see here.
This is a case for...
You can see me here with a technique where I'm using a simple hand lamellar blunt instrument to dissect that deep area of the cornea. And then basically put it together, as you can see here with this cross-stitch technique, bring them straight to excellent endpoint, and then do laser after that. So what does lamellar keratoplasty do? Lamellar keratoplasty decreases the keratometry, removes the scar, and increases the strength or thickness of the cornea for future laser surgery. You see again, I don't end here. It's my means to get to vision corrective surgery. This is a lamellar keratoplasty, then I do laser. Now, to me, even posterior corneal surgery like DSEC, DMEC, and all these techniques that I do are refractive. And when I do these techniques, if you can see there's a toric premium lens in this case, and in this case, radial keratotomy, a refractive complication, I'm actually doing my sutureless modified thin DSEC technique. This is day 1 with the air bubble, no stitches. Again, fixing refractive surgical complications should be refractive surgery. Cannot just do a corneal technique and go, I've changed your cornea, you'll see clearer. No, you want 20/20. So this is emmetropic refractively. Epikeratometry. Many of you may know of this. This is an old technique before lenses were invented, intraocular lenses. Doctors used to take the cornea, freeze it, turn it into a lens and stitch it on top of the cornea. So keratometry. And these cases today are flying to us with complications. There are a few of them done, not many, luckily. And here you can see me peeling off the keratometry because cornea never heals. That's the other beauty to remember. So I lifted off these EPICs 17, 20 years ago, and then put in a secondary lens, bring them to 20/20 vision. Here's keratometry on this gentleman, and he came to me with -6 myopia. So I told him, I'm going to do laser technique on you. I'm not even touching your cornea. And I meant it. I was working on his EPIK. I left it there, removed the scar, did the laser, brought him to 20/20, and that's where he is. Then we moved to phakic implant complications. Many of you have seen these kind of cases. Phakic implants, I had the privilege of working with the first study, perhaps in the entire US in the 1990s. We used the lenses from left to right. You can see the Momose lens up front, the Japanese glass lens, and then below the Fyodorov Collamer lens that's now become the ICL, and of course the worst lens from Holland. So you have all these lens technologies which are now developed, and the most commonly one, the Vision ICL that we use. And even those complications can be fixed, as you can see here, by exchange, by correcting with laser, by combinations, and bring these patients to excellent vision. Very, very important to me. Then we move to intraocular. To me, even cataract surgery is refractive surgery, has always been for 30 years. I don't know why right now doctors have suddenly decided that patients need to see perfect. Cataract surgery was always refractive surgery. So these patients flying to us because doctors are using premium lens technologies without understanding the implications. Just putting a lens in the eye doesn't guarantee vision, as much as putting an ingredient in a kettle doesn't guarantee an amazing outcome. You have to be a master chef, understand the recipe, and then perform the technology. So these patients come to us from excellent surgeons, brilliantly done surgeries, but they all are left what I call mid-zone. They were not taken to 20/20. So the patients are angry. And what we do with these patients is we take them straight to their target, which is vision. Very, very, very important. So these are very important ways of correcting issues. Even patients with multifocal lenses in RK cases can undergo laser plastique to 20/20 vision. Patients of these kinds, scars with real keratotomy with LASIK complications, correct the scar with laser plastique and then take them to toric premium lens, and you can take them straight to 20/20 vision again. Here are patients where you first stabilize the cornea. If it's an ectatic cornea from, say, LASIK or whatever, you stabilize the cornea, in this case with intact, and then I'm going into the eye, as you can see here, with the toric lens right there. So all you're doing all the time is within minutes, with minutes of elegant surgeries, taking these patients to vision, just like you do with your lenses and prisms and contacts. And just like that, surgeons have such an amazing armamentarium, but I want them to use it intelligently in minutes, in what I call small situations like Lego pieces, and match them to perfect vision. Here, for example, is an excellent case. Patient had 12 procedures before being sent over to me. Had keratoconus, had LASIK, PRK, PTK, cross-linking, ICL, intacts, everything, and vision 2200. Very, very angry. And now he had anterior cortical cataract too. So what I did is I left his cornea the way it was, corrected it with the laser, improved the scar so I could make it measurable. And then I proceeded to remove his ICL and the cataract, and then later follow up and go into his eye and put him a lens and go straight to 20/20 vision endpoint. So you can see me removing the ICL there. You can see I've left the previous doctor's intacts and everything in place. Did the cataract surgery, left the bag empty to measure it. There he is on stage 1. Stage 2, I'm putting the lens in a week later. Why a week later? Because I wanted to be more confident about the power of the lens. That's how finicky we must be to bring them to 20/20. And you can see that right there, the sequence of his vision. This is not Iceland to Paris. This is from Orlando to London to Paris. So it's forward. It's not going up and down. That's the sequence in this case we took stage. Thank you very much for your attention. I'm available for any questions, and you can always email us. And once again, thank you for your time.
Thank you so much, Dr. Gulani. That was indeed a wonderful presentation.